So welcome to the Talking Healthcare podcast series by medDigital and the Self-Care Forum. I'm your host, Dr. Felix Jackson, founder and medical director of medDigital and medCrowd. In this episode, I'm pleased to welcome Kevin Auton from Aseptika to discuss their initiative, which was highly commended at the 2020 Coronavirus Innovation Awards. Hi, Kevin. Would you like to give us a little introduction about yourself?
Thank you for having me. So my name is Kevin Auton. I'm the founder and managing director of Aseptika. By training, I'm a biochemist, but we have been working to develop solutions for self-care and supported self-management for the last 10 years.
Thanks very much. As I understand it, you've been developing some really innovative cardiac rehabilitation services, moving from kind of face-to-face in clinic to home monitoring service. Can you tell us a little bit more about that?
Yes, of course. The project in particular was to support patients as they were recovering from a heart procedure during the first lockdown of the pandemic. And what we wanted to do was to be able to provide patients who are in their process of recovering from a heart procedure, either elective or emergency if they'd had a heart attack and had a stent fitted, using our Activate Our Lives platform, which is a combination of medically certified cloud, app and devices, which links to the patients and also through to their care providers. And the objective was really to try and provide the same elements of a cardiac rehabilitation phase 3 program, but now deliver it at home, because many of the programs across the country had shut. And as we speak, as we're moving into perhaps wave 3 of the pandemic, many of them will still be struggling to reopen or to provide in-person care. And what we're trying to do is to work alongside the NHS long-term plan, which is really calling for more than 50% of eligible patients to receive a rehabilitation program, because we know that the combination of exercise, education, diet advice, all actually improve outcomes for patients, but only 50% of people who are eligible take it up. And the NHS with the long-term plan is really striving to reach the next 35%. So in other words, to get 85% of all eligible patients into some sort of program. So with that as a backdrop, obviously the pandemic happened, cardiac rehab shut, and we had the benefit of working with Eastern AHSN, Addenbrooke's Hospital and Sheffield Hallam University to very quickly roll out our program, which we'd been using and training patients face-to-face for quite some time. So we had some good evidence that it worked, but all the training was done in person. And so what we had to do very quickly was switch so that we could deliver this entirely remotely. So we recruited 55 patients who had heart procedures. They were sent the kit with the instruction manual and a video. We gave them telephone support, and then the cardiac rehabilitation team at Addenbrooke's then used the system to look at the patient's vital signs remotely just about once a week. So this isn't telemedicine or remote monitoring. This is very light touch, with the emphasis that the participants would really learn for themselves about the benefit of being active, increasing their physical activity, and tracking their vital signs, with the comfort of knowing that there was a nurse at the end of the internet connection, as it were, who was just keeping a watch over them rather than looking out for them. The study was then analysed by Sheffield Hallam University, and the results were really very positive.
Sounds really fantastic, and sounds like a really amazing initiative to do that switch during that difficult time last year when people really struggled to access their routine care. Out of interest, what kit was sent to these patients joining the rehabilitation program?
Well, what they received was a subscription to our app. They used their own smartphone, and they received a physical activity tracker, a wrist accelerometer, which we call BuddyBand 2, a set of smart scales, which measures not only weight, but body composition, which again talks to the app, a blood pressure monitor, and a pulse oximeter. And those that also had a respiratory condition, because around half of the patients not only will have a cardiovascular problem, but they'll also have a respiratory condition as well. Some of those were also sent a connected peak flow and FEV1 lung function monitor. And the idea is that you take your measurements once a day, takes around 10 minutes. And at the same time, you get sent very small 5-minute read education lessons through the app, and you work through the syllabus and you learn for yourself all the things that they would typically learn in a group-based or face-to-face program.
Fantastic. It sounds like a really interesting kind of set of, of technologies, but also support that you've rolled out there to help people kind of really track what they're doing from home. How do you make, really help the patients, the people in the program, to understand about their cardiac problems and why rehabilitation was so important?
Education really is the key to this. So we have 6 pillars of self-care, and education is number one. If we become educated and understand about our condition, then we are likely to improve our patient activation measure, or our PAM score, which is how engaged and how motivated we are to look after ourselves. And this is absolutely critical. If we share the education about how to take care of ourselves, and this is one of the great things of the work that's being done with the Self-Care Forum, if we learn how to look after ourselves, we're more likely to be able to catch things when they go wrong. We're more likely not to panic if something is happening that we don't understand, and we're more likely to adhere to our medication. So first pillar is education. Second pillar is support. We need just a little bit of help. Often it's just a little bit of advice or reassurance from an expert without having to go to A&E or without having to go to a GP. And that was why it was so critical that nurses were available to just look into or look out for each patient to give that reassurance. Third pillar is really having the tools to self-care, the monitors, and staying adherent to the medication, which is critical for these patients in recovery, is pillar number 4. Pillar number 5 and 6, these are trying to avoid the situations, and again, this is where education is important, which may cause our condition to kind of flare up or exacerbate again. And also, number 6 is to have a care plan, so we know what we're supposed to be doing routinely, what we do when things are going wrong, and what we do in an emergency. So all of this is really drilling for the event that something might go wrong again. And because we've got a good plan, because we know what we're doing, we know what our medications do, we're more likely to be stay adherent to our care plan, and we're less likely to have to need to go to hospital or go to a GP for an emergency visit. And during the pandemic, of course, this was absolutely key.
Yeah, that sounds really interesting. As regards the impact of your initiative, it clearly has had an impact and it's improved the lives of people going through this program. But do you have any data or any way to quantify that and tell us more about the impact that it really had?
Yes, and this is where the involvement of Sheffield Hallam University from the outset as the independent research partner was critical, because they were able to look at the data as it was being generated and then analyze it independently so that we could get meaningful outcomes. And in summary, what happened was we found that the patient activation measures actually increased about 5 points out of 100 over the duration. This is really significant. It relates to approximately a 10 to 20% reduction in the risk of future emergency admissions via A&E. What was really interesting is that different patient groups actually responded quite differently. The people who were already highly activated, already very motivated about looking after themselves, didn't show a significant increase because they'd already reached that point of high levels of activation. The patients who had the greatest benefit were the patients who are at greatest risk of another future event. So the ones who were perhaps slightly more frail showed a much bigger increase of around 10 PAM points, or points on the PAM score. And to turn this into sort of meaningful things that we can all understand, And these data were deemed statistically significant by Sheffield Hallam University in their analysis, is that the average blood pressure for the systolic blood pressure decreased by 6 millimeters. And high blood pressure, of course, is very closely correlated to ongoing heart disease. Their waist circumference on average decreased by 7 centimeters. So this is a very good measure that belly fat was being lost. So as people were exercising more and reducing their weight, the fat area, the visceral fat around the vital internal organs, which is again linked to diabetes, decreased. They all reported an increase in physical activity. And what was really surprising for us was that the completion rate of a 12-week course was up to around 93%, whereas nationally the in-person completion rate is around 77%. And there's again a very strong correlation between those who complete the 12 or 8 or 12 weeks in person and the reduction in future attendance to A&E. So in other words, if you're motivated, if you go to the classes, if you make lifestyle changes, if you become physically active, if you learn about your condition, you're far less likely to go back into hospital.
Yeah, I mean, those are really impressive results. And it's fantastic to see that you haven't just rolled out a new program, you've also measured it and taken time to really understand the outcomes and see the impact in real detail. So it's very impressive to see that. Do you have any advice for organizations that might need to do something like this? You know, other organizations that might be trying to move some face-to-face care to a remote setting. What could you give them as advice?
The number one piece of advice that I would give is, first of all, work with your local academic health science network. We're very fortunate that we have a close relationship with not only Eastern, but also the Yorkshire and Humber AHSN. Second thing you need to do as part of that is to work very closely with the clinical team, because this is often going to be a very new pathway for them. There are a lot of barriers and challenges. The money will need to flow differently. Commissioners need to be involved. So it's important that all stakeholders are involved in that process. And the other aspect to this is to involve a academic or a clinical uh, research group who can actually independently do the research with the results and the outcome, because ultimately commissioners of future services are going to want to see evidence to see, does this program work? Is it cost effective? Does it save me money? And if you're looking to take a new pathway and get a nice recommendation so that the technology can be funded under the medtech mandate, funding mandate that has just been introduced in April of this year, it's absolutely crucial that you have the evidence of clinical improvement, the evidence of cost saving, and you've got to be able to show that it's cost saving in year one. So there's a lot of threads that you have to bring together, and you have to have everyone on the team working in the same direction from the outset. So as with all these things, preparation is key, unless you have lockdown and they just have to get on with it.
Yeah, that's really interesting. And it shows a lot of the challenges that you must have faced to get this going. The fact you've got so much advice for other organizations shows that you've had to work through so many complex issues, but impressive to see the results that you've actually got at the end. So thinking specifically about patient activation, getting patients involved in a program like this, do you have any advice or any key learnings that you might have identified around specific patients and how to bring them on to this program?
That's a really good question. Looking at the composition of patients who were self-selected, they had to want to do this because the alternative was to do nothing. And, some people still chose to do nothing. There's a couple of really interesting trends. Age is not necessarily a barrier. If you are actively curious and you enjoy using technology, then age isn't a barrier. So it's not a case that older people can't do tech. That simply isn't true. I know lots of young people who can't do tech very well either. So it's not necessarily related to age. I think the key thing is that the clinical staff have to be very supportive of it. And the patients have to get confidence that the clinical staff, the influencer, is absolutely behind the initiative. And in this case, with the team at Adam Brooks Hospital, they were clearly very dedicated and wanted to keep their service for cardiac rehab going when other centres around the country, frankly, just shut because they were either being reassigned or they had no alternative. So I think you've got a hearts and minds challenge, not only with the patients, but particularly with the clinical influencers. And if they're behind it, then the patients will. And that is the number one critical thing. The second element of this is that you've got to be prepared for what we might call edge cases, people who don't necessarily want to do things in a certain way, but do actually want to have the benefit of it. So, for example, where there is absolutely a genuine case of digital poverty, we found that we had to have tablet computers with 3 or 4G data ready available on those rare occasions where people didn't have access to Wi-Fi or a smartphone, etc. But that's increasingly rare. So you have to be prepared for those edge cases, but actually not allow those edge cases to prevent the majority from accessing the technology. And I think there's often a situation whereby we tried to reduce everything to the lowest common denominator rather than try and work on the 80-20 rule. And finally, I think the final aspect of this is that there's nothing that's perfect for all of the people all of the time. So we've got to really come up with a buffet of different solutions. Some people will like in-person groups. Some people will hate in-person group works, but will want one-to-one. Some people may want a hybrid where they may want to see other people, at least to start with, and then move to a digital variation, particularly once they've learned how to do certain exercises or get the form of the exercises right. So being open to have a range of different choices so that you can meet the needs of most people most of the time. And also being prepared to be flexible to have a hybrid or a joining of different solutions is going to be key. And that's quite challenging when an outpatient system is driven by an appointment system. So I think we've got a lot of challenges to overcome going forward, but the virus is clearly not going to be going away. It's going to be with us for quite some time. So we are going to have to face these issues quite quickly.
Yeah, it's very interesting, and it's really interesting to hear the challenges around people who may not have internet access and smartphones, mobile devices, etc. Because also, often that's linked with people who need the most support. So we really need to continue to consider that in the future.
Absolutely. And we know that there are real barriers to joining a rehabilitation program, whether it's cardiac or pulmonary, respiratory. We know that rural isolation is an issue. We know that gender is an issue. Women are less likely to go because they've got family caring responsibilities as well as being in the process of recovering their own health as well. And we know that poverty, not being able to access transport, not being able to access digital technology is another major barrier. So society has got to work out how do we make sure that there is equitable access to these services so that no one's excluded.
And clearly, your initiative was kind of supercharged by the pandemic. The need for it really came to the fore. What do you think about after the pandemic? Will this continue?
Yes, I think it has to. With the virus looking like it's going to be with us for a long time and blended services becoming perhaps the more standard, what we're going to see is initiatives like this being used alongside in person. Not one is better than the other, but rather we need a range of different things for a range of different people. And so for us, the next step is to really move this to a multi-center randomized controlled trial. So 1,000 people, 1,000 patients, so that we can submit the evidence to NICE, get hopefully a nice recommendation, demonstrate that the health economics works, that there's a cost saving, and so that this can then be adopted nationally. So it's a long, long road.
Well, Kevin, thank you very much for joining us here today. It's been an absolute pleasure talking to you about your impressive initiative, and it's really interesting to see how digital technology has come to the fore in the pandemic, and you're using it in such a smart way to really support patients through their cardiac rehabilitation journey.
Thank
So
you for
thank you very
having me.
much. It's been a pleasure.
Thank you.